My name is Dr. Khaled Abdeen. I am a neurosurgery and spine consultant, and my main interest is spine surgery. My topic today about the low back pain and lumbar spine, and we will focus our topic today about the low back pain, the anatomy of low back pain, the different causes of low back pain, uncommon causes of low back pain, the update in the diagnosis and in the management of low back pain, and also we will make focus about the different modalities of surgical technique. And I try in my presentation today to focus about the minimally invasive spine surgery. This is the update, or what's called the new era of spine surgery. So now we are in the era of a change from the spine surgery traditional to the minimally invasive spine surgery. And also I will give a small hint about the future of spine surgery and the role of molecular biology and the stem cell in treatment of degenerative disc disease, which is a common problem. We will start now our topic today about the low back pain. Low back pain is the most common reason for visits to the clinic of orthopedic, to the clinic of spine and neurosurgery, to the clinic of pain clinic. And in the United States, they estimate the cost, it reached to $50 billion per year. So it is a major problem. We must give proper diagnosis, aiming for proper treatment for this problem. As we know, the anatomy of spine, we can summarize into very simple unit. It is what's called spinal unit. What's meant by spinal unit? It is consist of two vertebrae, and in between there is intervertebral disc. The aim of this intervertebral disc, it acts as help the flexion and the extension of the spine and work as shock absorber. So the disc have a good role to maintain the stability of the lumbar spine. So if we look here, this is the lumbar disc between the two vertebrae, and here is the posterior spinal complex, which have good role in maintaining the stability. Also here we mention the different vertebra with intervening disc in between, and here is also the role of the facet complex in maintaining the stability for the spine. Now we will discuss what are the different clinical presentation of patients presented with low back pain or lumbar vertebral problem. We will discuss first group of patients which are presented by back pain only, in the form of limitation of movement, in the form of paravertebral spasm. And this indicates there is muscle spasm with underlying some sort of degenerative disc disease or affection of the stability of the spine, which is called potentially unstable lumbar spine. There is other group of patients presented with back pain with bilateral gluteal and hamstring pain. And this reflect very important problem, which is spondylolysis or spondylolisthesis. And in these patients, if you are in the clinic for spine, you must request in this group of patients dynamic X-ray, which means AB and lateral, because this will give you the diagnosis of spondylolysis or first degree spondylolisthesis. The most common is the back pain and sciatica. This is the most common patients complaining of low back pain and sciatica. And this is the role of the physicians to know that these patients, which root is affected, either L4-5 disc or L5-S1 disc. And also sometimes it is either uniradicular or polyradicular. And the most important for these patients are the patients complaining of neurological manifestations. For example, you must give good attentions, good examinations for patients coming with weakness in the dorsiflexion, with foot drop, weakness with plantar flexions, because these patients, of course, need urgent investigations, need urgent management. This is the group of patients not indicated for conservative treatment if our patients have neurological deficit. So it may be monoradicular or polyradicular. The most important here is the coda equina syndrome. This is a neurosurgical and spinal emergency. Why? Because these patients is presented to your clinic by bilateral foot drop, bilateral lower leg numbness with sphincteric disturbance, and this indicating severe compression in the neural structures. And there are many causes for this. The most common is the lumbar disc, but maybe spinal tumors, maybe metastatic tumors, maybe spinal tuberculosis, maybe different causes. So these patients need urgent investigations and urgent management. Patients with Coda equina syndrome. The causes of low back pain we will classify into degenerative causes, and this is the most common. Cases with spinal stenosis, cases with spondylolisthesis, and cases with spondylolysis. And traumatic cases, and also there is inflammatory arthritis. The most common is patients with ankylosing spondylitis, and in these patients, if you suspect chronic low back pain, in young patients, we proceed for HLA-B27s, and also we must ask the opinion of our colleague rheumatology consultant, and also patients with rheumatoid arthritis. I need here to mention that if patients, for example, with low back pain and associated rheumatoid arthritis, please don't misdiagnose the underlying osteoporosis. Why? Because patients of rheumatoid arthritis have restricted movements. Patients with rheumatoid arthritis are receiving steroids. Patients of rheumatoid arthritis have autoimmune disorder. All are predisposing factor for osteoporosis, which called the silent disease. The other group of patients are infection. What mean by infections? There is maybe staph infections. This can cause discitis, can cause vertebral osteomyelitis, and also TB spondylitis. TB spondylitis is common in our area in the Middle East, especially in some countries, due to overcrowding, due to malnourished, due to bad habits of smoking, and bad nutritional factors lead to there is some cases of spinal tuberculosis. Also, brucellosis is one of the causes of infections. And when we come to spinal tumors, the spinal tumors are classified into extradural and intradural. Unfortunately, the most common is the extradural tumors. Extradural tumors, there is metastatic diseases, there is lymphoma, and there is myeloma. Intradural, there is most common is the neurofibroma. And don't forget osteoporosis in the management of patients with low back pain. There are some causes of extraspinal causes. What mean by extraspinal causes? For example, patient with aortic artery dissection, this can cause bilateral sciatica. Second, patients with hip disease, the hip disease can cause referred pain to the knee joints, misdiagnosed as sciatica. So in this case, if you suspect these patients, please consult our orthopedic colleagues for the diagnosis of this problem. Now, one of the new era for the management of low back pain is the minimally invasive spine, because these techniques depend on the new technology and the new digital technology in what's called intraoperative image guidance, and it aims to minimize the soft tissue trauma for better outcome for patients with spinal problems. Here I will make focus about the improvement in spine surgery. Improved in spine surgery depend on many factors. But for example, this is one of the OR. Here we can see this is the endoscopic procedures. Here is the improvement of image guidance. Here the improvement of MRI and the back system inside the OR. Also the use of new minimally invasive instruments, and also neurophysiological monitoring, and the use of CR, the use of Midas Rex, the use of microscope. So all these new instruments and the updated technology aiming to improvement in spine surgery, improvement in minimally invasive, and improvement in the outcome for our patients. This is the image of the OR. This is intraoperative CT imaging for 3D localizations. For example, if you need to spinal fixation and spinal fusion, this can give you guidance for the entry for the pedicle, for example. And this is the neuronavigation system. This can be very helpful in the fixation. For example, if you have patients with recurrent spinal surgery. If these patients with recurrent spinal surgery, there is many adhesions, you can lose your anatomy, so the navigation system will give you the good entry for the pedicular screw inside the pedicle. Here, this is the image for the intraoperative neuronavigation for the insertion of pedicular screw. And here, this is diagrams showing the disc. For example, on the right side, this is a disc bulge compressing the nerve root. And this, of course, leads to the sciatica. And on the left side, here is a disc herniation with protruded disc and this compressing the nerve root. If already have patient with lumbar disc and no neurological deficit, in this situation, you will proceed for conservative treatment. But if you decide to surgery, before the routine surgery is laminectomy, but laminectomy will lead to instability. So now we are in the era for minimally invasive procedures. We can do interlaminar approach for fenestration to remove the disc prolapse. Or you can do this technique under what's called, you are using tubular retractor. This minimizes muscle trauma and you are directed to the target of the disc prolapse. And now the update is the endoscopic surgery for lumbar spine. Here, the endoscopic approach through the foramina, what's called percutaneous endoscopic lateral approach for the disc through the foramen. And here, this is during the operative procedure. And here, this is the operative photo during the endoscopic lumbar spine surgery. And here, this is another MRI showing the good localization for the disc fragment to localize your target towards the removal of the disc through the endoscope. And here, this is the instrument used for the endoscopic discectomy. Here, this is the tubular retractors to decide the access for your instruments. And here, this is the micro instruments for the endoscopic technique. And here is the picture of the endoscope used. And this is during the procedure. And here, during the use of the endoscope while localizing the entry point through the use of C-arm fluoroscopy. The second type of the causes of low back pain, we mentioned the lumbar disc and the degenerative disc disease. The second most common cause is spinal stenosis. What is meaning by spinal stenosis? If we look to this CT, we will find 3 radiological findings. First, disc bulge. Second, facet hypertrophy. Third, ligamentum flavum hypertrophy. So, if you need to treat this spinal stenosis, you must treat these 3 pathologies. If we look to the degenerative cascade for lumbar canal stenosis, there is changes on the facet, start by facet inflammation, synovitis, and the facet hypertrophy. And the facet hypertrophy lead to lateral compression in the nerve root. And also the changes in the disc, it start by disc degenerations and black disc and what's called potential instability. Some cases have some potential instability. During flexion and extension, the patient will have some sliding movement for the spine. And of course, all these factors lead to compression on the neural structures leading to spinal stenosis. This slide shows during extension, there will be decreased in dimension for spinal canal. While during flexion, there will be widening of the spinal canal. So, if you found old age patients coming to you in flexion attitude, he need to widen the spinal canal. Because in extension attitude, this can cause back pain and it can cause the clotting sciatica. The diagnostic point for the lumbar canal stenosis is patient presented with low back pain and bilateral claudicating sciatica. That means the pain increased during walking. What's called meaning walking distance. What are the treatment options for patients with lumbar canal stenosis? Of course, we can classify it into conservative group and surgical group. When we mean a conservative group, we'll start by giving the patients some back support. We give him muscle relaxants. We give him non-steroidal anti-inflammatory. We can try to give him some pain reliever like epidural analgesia. And in some cases, we can proceed for surgery. Surgeries, there are different options. Either you do laminectomy, but this leads to instability. Or you can do interlaminar decompression. This leads to just decompression the stenotic segments. And also, the new minimally invasive procedure for lumbar canal stenosis, or what's called interspinous spacer. Interspinous spacers are inserted between the two spinous processes, aiming to indirect distraction. This indirect instructions will lead to widening of the foramen. This post-operative X-ray showing in the middle here there is laminectomy with fusion for the lumbar spine. Here we did the fusion by two components. The first is the transpedicular screws, and if you look to the lateral area here, there is posterolateral fusion by the bone. The interspinous posterior stabilizations, as we mentioned, it leads to indirect distraction for the interspinous space, and this leads to unfolding of the folded posterior of the ligaments, and also lead to indirect widening for the vertebral foramen. Here different illustrations for the interspinous spacer. Here is the CT. Where is the location for our spacer? Here. But of course, if have some complications, there may be displacement for these spacers, but it is indicated if the patient is old age, if the patient is inoperable case, we can put, because we can do this procedure percutaneous technique. This is here is the post-operative X-ray. In this CT, I just mentioned one of the rare causes for the low back pain and sciatica. Here there is ossification in the ligamentum flavum. If we look here, and there is ossification of the ligamentum flavum, and this of course leads to spinal stenosis. And we need here to mention that ossified ligamentum flavum is part of DISH syndrome. DISH is diffuse idiopathic skeletal hypertrophy. If you found one CT with this diagnosis, please don't miss the diagnosis of cervical OBLL. Yani that means if I see this ligamentum flavum, immediately I will request MRI or CT cervical for cervical OBLL. One of the common causes of low back pain is spondylolisthesis. Spondylolisthesis is forward displacement of one vertebra over the other due to either defect in the pars interarticularis in this area, or due to fracture of the pars interarticularis and lead to sliding movement. Of course, this sliding movement will lead to degree of compression on the neural structure. The management for spondylolisthesis, one of the treatment options is we proceed for posterior lumbar interbody fusion, either by bone or cages, with use of transpedicular screws. The other option, you can put interbody cage. What is the advantage of interbody cage? Interbody cage are aiming to prevent the collapse of the vertebra, and also aiming to get a high percentage of fusion, and also it leads to indirect widening of the vertebral foramen, and this of course one of the causes of decompression for the nerve root. The cages you can put stand-alone interbody cage, but there is percentage of displacement. So the second option is combined fixations. You use interbody cages augmented with pedicular screws. This is biomechanically will lead to sound fusion. The other option for fixations is you can go through anterior approach. You can do anterior lumbar interbody fusion either by bone graft or by interbody cages also. The new era now for the insertion for pedicular screws, we can do through surgical technique, but now the new era, we can do this technique through percutaneous insertion of pedicular screws, and this will depend, as I mentioned before, insertion of guide wire followed by the dilators. After that, through special instruments, you can put your screws through percutaneous technique with incision only 1 centimeter. One of the update for spinal fusions, what's called dynamic stabilizations. Normally, if we put one screws here and put one screws here, we will fix and connect to by hard metallic rod. This hard metallic rod will lead to rigid fixations. What is the advantage of rigid fixation? It leads to adjacent segment failure. So now one of the new techniques is called dynamic stabilization. What I mean by dynamic stabilization is we maintain some motion in the intermediate segment here, in this area, to prevent adjacent segment failure. So, for example, these patients, we can do in L5S1 rigid fixations. But in L4-5, as it is just degenerative disc disease with no marked compression, so we can do in this segment dynamic stabilization. Here, this is the post-operative X-ray of the dynamic rods, or what's called soft stabilization. It is not rigid stabilization, it is called dynamic or soft stabilizations. One of the, it is difficult approach for the spine, but biomechanically it is very good for the lumbar spine, which is the anterior approach to the lumbar spine. What is the advantage of anterior approach? As we know, the posterior element maintain 20% of the stability, while the anterior column maintain 80% of the stability. So if my approach focus on the reconstruction of the anterior column, this will lead to better outcome for the anterior column. Here, if I look to this patient, this is cases of fracture spine with retropulsed fragment. This retropulsed fragment compressing the dura. So in this technique, we decided to proceed for thoraco-abdominal approach, aiming for corpectomy and removal of the retropulsed fragment, followed by vertebral body replacement by cage. And here the cage is filled with interbody graft, and this is augmented by an anterolateral plating and screws. So finally, we reach to the area here. If we look here to the area of anterior column reconstruction with good stability for the lumbar spine. This is the 3D reconstruction of one patient with anterior column reconstruction with cage augmented by screws. Now we will mention one of the update of the management of lumbar spine, which is if patients presented with fracture L2, for example, and this patient during the preoperative investigation there is osteopenia. So in this group of patients, if you proceed for fixations and the bone structure is weak, so these patients are susceptible to screw loosening and failure of your implant. So how to solve this problem? There are many procedures to manage the osteoporotic vertebral fractures. But one of the techniques is what's called augmented fixations. What I mean by augmented fixations? First, we inject cement inside the vertebral body, And after the insertion of the cement, you will insert your screws smoothly inside the cement. After that, the cement will be hard enough to make captures for the screws inside, and this will lead to good stability. Here, the CT showing the intravertebral bone cement, and the pedicular screws now are surrounded by cement. And here, this is the screws. What is the advantage of this technique? This leads to good grip for bone cement and prevent the failure of the instrumentation. This is one of the most important causes for low back pain and sciatica. This patient is presented with low back pain and left radicular pain, left sciatica. The same clinical pictures like patients presented to our clinic with lumbar disc. But MRI shows to us here intradural spinal tumors. This is the spinal tumors. Before, if we face this problem, we found patient with intradural tumor, so routinely we can immediately proceed for surgery and do laminectomy. After laminectomy, you do dural incision. After that, we remove the tumor. But what is the update now, according to Professor Brzezinski from Mainz University in Germany, is what's called keyhole surgery. This is one of minimally invasive approach for the spine. Keyhole. Here, this is the keyhole surgery. I did the surgery and I keep here the facet, the lamina, and the spinous process. I just do limited laminectomy in the side here. After that, I do small dural incision, and through microscopic technique, you can remove your tumors. The advantage of this procedure, first, you avoid laminectomy, because laminectomy leads to late instability. If you do through keyhole spine approach, that means you are maintaining the stability of the spine. So this is the post-operative 3D reconstruction of the CT. And here showing very clear the limited small window that help us to remove the intradural tumors. This is one of the update in spine surgery, is keyhole approach for spinal tumors. This is the preoperative MRI of neurofibroma, and here is the post-operative after total removal tumor. This is another patient presented with metastatic deposit in L2 vertebra. This patients presented with gradual progressive paraparesis. First, to diagnose these patients, we must do metastatic workup, try to search for the primary source of the neoplasm. And we decided for surgery, but we know this is metastatic deposit. Metastatic deposits means this tumor is vascular. One of the updates for spine surgery also, to minimize the bleeding, we can depend on teamwork with our endovascular surgeons to do preoperative embolizations. And we can do the preoperative embolizations, for example, if patients with vertebral hemangioma, if patient with metastatic deposit, because these are vascular lesions. So preoperative endovascular will minimize the bleeding and lead to successful surgery. After endovascular embolizations, we did the corbectomy, and we insert here the titanium cage mesh for anterior column reconstruction. This is the intraoperative photo. And here this after insertion of the anterior plating augmented with bone substitutes to enhance the bone fusion. This is the post-operative X-ray showing good anterior column reconstruction after excision of metastatic deposits. Here, this is the X-ray of patients with ankylosing spondylitis, and this will depend on our colleague rheumatology consultant to do the further investigations and the treatment of this group of patients. Here, this is the skull X-ray showing multiple deposits due to multiple myeloma. This is one of uncommon causes for low back pain. Now I will give a small talk about the spinal tuberculosis. Spinal tuberculosis nowadays is going up. There is now many cases of lumbar tuberculosis, dorsolumbar tuberculosis, spinal tuberculosis. And 1/3 of this group of patients are associated with pulmonary tuberculosis. If I look here to this MRI, we can show here this is the pulmonary focus for tuberculosis, and here this is the axillary lymph node of tuberculous lesion. This is associated lesion with one patient with spinal tuberculosis. He presented with low back pain due to spinal tuberculosis, but during examination the gait is ataxic. That's why I decided to do for him MRI. There is two cerebellar lesions. This is cerebellar tuberculous lesions. Unfortunately, with the start of anti-tuberculous treatment for 9 months, this is the update, not 18 months, there will be a good improvement in these tuberculous lesions. This is another patient with affection of the left hip due to B. This is the classical case of spinal tuberculosis. It is dorsolumbar tuberculosis with collapse of the vertebra leading to epidural abscess and spinal compression. And in management in this case, the best approach for these patients is anterolateral approach aiming for decompression and stabilizations. And after that, you continue the anti-tuberculous treatment for 9 months. This is the destructive lesion from the CT with the tuberculosis, and here is a paravertebral collection. This is the post-operative after good fusion. This is another case of spinal tuberculosis, 12-year-old male, but from the history, there is overcrowding, there is bad nutrition, and this leads to development of low back pain with some kyphosis. And here, very clear on the left side, the large paravertebral abscess, and on the other CT, there is collapse of the vertebra. The management for these patients, of course, will be evacuation of this large abscess, followed by posterior approach for the transpedicular fixation, aiming to stabilize the vertebra and to prevent the progressive kyphosis in this young child. One of the most important points related to the spine, whether it is lumbar or cervical spine, if patients who is presented with hip fracture, is osteoporosis. Here, this is the electro-microscopic photo, shows the microfracture in the trabeculae, at the end, affection of the bone quality. What is the result? Will lead to vertebral fractures, or can lead to hip fracture, or can lead to wrist fracture. We must mention this point. Only 30% of patients with vertebral fracture are clinically diagnosed. That means this is the role of physician to examine the patient, to take good history, to diagnose patients with asymptomatic osteoporotic vertebral fractures. Because if you suspect these patients have osteoporotic vertebral fractures, in this group of patients, we must treat first the vertebral fracture, second, we treat the osteoporosis. What are the risk factors for osteoporosis? Risk factors: if female above 45 years, postmenopausal age. Second, if there is positive family history. Third, if there is low calcium intake. Smoking, and alcohol user. Because now we are in the new era that many of the females are smoking. Smoking in female, and especially postmenopausal age, all these factors lead to the development of osteoporosis. The vertebral compression fractures will lead to some important points, because this will lead to kyphosis, will lead to chronic back pain, will lead to affection of the respiratory functions, and lead to what's called long-term complications. One of the important points, if one patient have osteoporotic vertebral fracture, That means these patients will have 5-fold increase for what's called second fractures. So if you diagnose first fractures, you must treat the patients before the development of other vertebral fracture. This X-ray on the left side, this is the normal, healthy X-ray for the lumbar spine. Unfortunately, on the left side, there is osteoporotic changes. We must know, if you suspect that this X-ray is osteoporotic X-ray, that means there is more than 40% of bone loss. So you must treat your patients before the affection of the bone quality. One of the treatment options for the osteoporotic vertebral fractures, first, we must start by conservative treatment, by painkiller, by analgesic, by the treatment of osteoporosis. And we give patient bed rest and back support. After 6 to 8 weeks, if this patient is still complaining of pain and not responding to the conservative treatment, that means we must proceed for the new technology for minimally invasive spine is percutaneous technique, either percutaneous vertebroplasty or either percutaneous kyphoplasty. Here, this is the post-operative CT showing the cement inside the vertebral body in 5 levels. And here, this is percutaneous techniques for 4 levels, injection of the cement through the pedicle into the anterior 2/3 of the vertebral body. This is a simple technique. It depends on percutaneous technique, simple instruments, but it needs to good localization during the surgery. This is machine is aiming to adjust the viscosity for the semen before injection into the vertebral body. This is also post-operative CT. The other technology for the percutaneous treatment for osteoporotic vertebral fracture is kyphoplasty. What is the importance of kyphoplasty? Vertebroplasty has the complication of cement leak. Cement leak can lead to neural compressions or also can lead to pulmonary embolism. So kyphoplasty meaning you will inject your cement inside a balloon. This will minimize or prevent the cement leak. That means percutaneous technique through guide wires. You inflate your balloon. After inflation of the balloon, you inject the cement inside. This is a technique for kyphoplasty. Here, during inflation of the balloon, after that, you will inject the cement. So, in my topic today, I mentioned different procedures for the minimally invasive neurosurgery, starting from the endoscopic technique, starting from augmented fixations, and the percutaneous screws, and the dynamic stabilizations, and also the osteoporotic treatment by percutaneous vertebroplasty and percutaneous kyphoplasty. What is the advantage of this minimally invasive spine surgery? First, it minimizes tissue trauma and minimizes the blood loss. And also it minimizes the post-operative pain and minimize the hospital stay and minimize the recovery period and allow the patient to return early to his work. And at the end of my presentation, thank you very much. And our aim is to make the spine of our patients is so strong like the stones of the pyramids in Egypt. And thank you very much, all our colleagues. Thank you.